We're going to discuss some high-yield cases, and then we're going to cover some USMLE cases scenarios at the end. So we're going to see some guidelines, and we're going to see some cases. And before we start, I want to give a quick shout out to MAS, or I think Mr. AS, for being my very first Patreon. Of course, Patreon get exclusive videos and quizzes other than the ones that we post on YouTube. Anyway, so let's start. The first guideline that I want to cover that I feel is very important is blunt trauma to the abdomen, or blunt stomach trauma, basically. So if somebody is having pierced abdomen with a knife or bullet or whatever, that's probably going to be surgery and has a lot of guidelines of its own of whether or not the object is rusty, whether or not you have the objects or not. But that's another topic. Today we're going to cover the blunt abdominal trauma. So for blunt abdominal trauma, basically, actually, wait, let me just cover open this one. Okay. So basically, for blunt abdominal trauma, if you have peritonitis, this indicates that there is an active bleeding or an active inflammation by perforation of any abdominal content, most likely the stomach or the intestine. So peritonitis is a sign that there is a big thing that is going on in the abdomen, and we need to take the patient to surgery immediately. Peritonitis signs are basically rigidity, tender abdomen, guarding, sometimes fever. So think of anything that would irritate the abdomen so much that really basically touching the abdomen is very painful. This is a sign of peritonitis. The patient needs to go to the OR immediately. But if the patient does not have a sign of peritonitis, so we go one of two cases. First, we're going to do FAST, which is the focused assessment abdominal scan, whatever. It's basically ultrasound of the abdomen, taking ultrasound at different locations. And if the ultrasound shows fluids in the abdomen, this indicates an active or a bleed that have already occurred in the abdomen. So if you see, if you see fluid in the abdomen, then you can treat the patient conservatively if they are vitally stable. And if they are vitally unstable, take the patient to the OR. So basically, blunt abdominal trauma, it all goes back to the patient's stability. If the patient is stable, they can they can basically be treated conservatively, given that they have no fluid in the abdomen. If they have peritonitis, then they're likely to have other issues, and they have to go to the OR. Okay. Speaking of the abdomen and the intestine, let's talk about ingesting foreign objects, especially in pediatric. So in pediatric, patients will often ingest or basically swallow either small toys or sometimes coins, sometimes magnets, stuff like that. So the guideline goes as follows. If the object is very small, like a coin, which is the most common case, so basically we just, the patient came to the ER, we basically just do X-ray, serial X-ray every 5 hours to make sure that the object is indeed moving. So if we see that the object is already in the stomach, for example, given the object is a coin, we just wait for a couple hours and take another X-ray to see whether or not the object have moved to the intestine, and then another X-ray a couple hours later to see whether or not it moved to the large colon, for example. So we just follow up the object. And if at any point the patient developed hemodynamic instability, they need to be taken to the OR. Now, that's for blunt objects or roundish objects like coins and non-harmful objects. The other scenario is one of three things that are very, very serious. Either magnets or sharp objects or batteries, yeah. So magnets, sharp objects, and batteries. These three need to be taken care of. Basically, you have to be very considerate and careful when dealing with these objects because they can cause irritation or perforation, and hemodynamic instability can be basically imminent. You're going to be standing on your toes waiting for them to happen. So in these patients, of course, if they swallow one of these three objects and you did chest X-ray and you saw the objects either in the esophagus or in the stomach, you're going to have to do endoscopy to take out the object. If the object is past the stomach, then you're only going to have to do X-ray to wait out the object till it reaches the colon. And as soon as it reaches the colon, you need to do colonoscopy to extract the object. So we need to get it out as soon as possible. And of course, if at any point while you're waiting, the patient developed hemodynamic instability with increased heart rate and low blood pressure, or basically going into a coma or whatever, this indicates that there is an active perforation or an active issue, and the patient needs to be taken to the OR and the object extracted surgically. Okay, so basically, blunt objects, coins, which is the most common case, we just wait it out. We don't really need to do anything. If the patient already extracted the object, like they went to the bathroom and the object is already passed, then you don't really need to do anything. Like they came to the ER after the whole thing is over, then that's that's basically it. You don't need to do anything. Okay. So that's for objects. Okay, migraine medications. These are very common. You will definitely get a question about migraine medications, either prevention or abortion of migraine episode. So patients of migraine basically have recurrent episodes of headache every now and then, and certain patients have certain triggers that are associated with their headaches. Some patients feel headache whenever they eat, for example, spicy food. Other patients feel headache whenever they have bright light, like the sun or a flashlight or whatever. So every migraine patient knows what triggers their migraine. And sometimes the trigger is unavoidable, for example, loud sounds. And you cannot just walk down the street expecting that nobody's going to make a loud sound. So these patients need to take a preventive therapy that prevents the migraine from happening if the causative trigger happens randomly. And of course, if the episode already happened, they have to take a different medication to stop or to abort the headache. So migraine medications are two classes: prevention, which prevents the headache from occurring in the first place, and abortive, which basically aborts or stops the migraine episode once it's already started. The preventive medications are, of course, we have three medications here and three medications there that you need to know. So the preventive therapy always starts with topiramate, and then we go for beta blockers, and then we go for TCA or tricyclic antidepressants. So these are the guidelines that you need to follow for every patient. Patients who are having, basically to prevent the migraine, basically we start with topiramate, and if the patient doesn't show any response and they continue to have episodes while they're using topiramate and they adhere strictly to it, then they need to be changed to beta blockers. And if beta blockers do not help in preventing the migraine headaches, then we go to the third line, which is tricyclic antidepressants. So topiramate, beta blockers, and tricyclic antidepressants. Something that you might see in the exam, if a patient was pregnant, we cannot really use topiramate, so we use beta blockers first to prevent their migraine. So if the patient is already taking topiramate all the time and they're adherent to it and it shows good results, and then the patient become pregnant, we switch topiramate with beta blocker. Okay, so that's for preventive therapy. For abortive therapy, we have different medications. We always start with sumatriptan. This is the first line to stop the episode once the headache has already started. And once we use sumatriptan, if it doesn't show any results, or the patient feels that the results are not sufficient enough, we can use the second line, which is NSAIDs and acetaminophen, which is basically paracetamol. The third line is ergots. So these are basically the abortive therapy of migraine headaches: sumatriptan, NSAIDs or acetaminophen, and ergots. Okay. The last topic that we're going to cover before we go to the cases is premature rupture of membrane. Of course, the normal rupture of membrane should occur immediately during labor or just before labor. And this normally occurs around 38 weeks of gestation, take or give, but 38, 39, 37, something like that. If the membrane ruptures before, we call this premature rupture of membrane, or PROM. So we have a certain guideline on how to deal with these patients. If the membrane ruptured before 34 weeks of gestation, so 34 or less, the patient has to take antibiotics and steroids. Antibiotics or steroids are the gold standard. You're going to give them to every case of premature rupture of membrane. And by the way, premature rupture of membrane is mostly caused by bacterial infection in the vaginal tract. Mainly group B streptococci or E. coli, one of those two. But I think group B streptococci is more common. So if any patient developed premature rupture of membrane before their labor date, we give them IV penicillin and we give them steroids. Yeah, steroids for lung maturation, IV penicillin to prevent infection from reaching the baby. If the 34 week is one of the first stop points that we have, if the membrane ruptures before 34 weeks and the patient is stable and they don't have any complications, we just give them penicillin, we give them steroids, and we wait till they go to natural delivery. Of course, during this time, they have to be in the hospital because labor is going to be imminent at any point. If there is any complications like infections, like fever, like maternal compromise by bleeding or anything else, then we give them penicillin, we give them steroid, and we deliver immediately. Now, if the patient already passed the 34-week gestation period, and then they have premature rupture membrane, we, of course, because this is not the normal labor period, this is before 38, So we give them penicillin, we give them steroids, and we deliver immediately. So basically, 34 weeks. Before 34 weeks, we give penicillin, we give steroids, and we wait. Or if there's maternal compromise, we deliver. In more than 34 weeks, we give penicillin, we give steroid, and we deliver anyway. Now, there is another medication that we sometimes give, which is magnesium sulfate. We give this to accelerate the maturation of neurons. Of course, we give steroids to accelerate the maturation of the lungs, but we give magnesium sulfate to accelerate the maturation of neurons and the neural system in patients who have who are having premature rupture of membrane less than 32 weeks of gestation. And of course, like we said, bacteriuria or bacterial infection of the vaginal tract is the most common cause of premature rupture of membrane. Okay. So these are all the topics that are prepared. And let's go to the quizzes or the cases. So our first case is a 30 weeks pregnant woman who came to the ER complaining of absence of fetal movement for the last 6 hours. The ER physician performed a non-stress test. The results of the test were inconclusive. Which of the following is the best next step? And the options are to repeat the non-stress test, or to perform a biophysical profile, or to deliver immediately, or to assure the patient and just send them back home. So which of the following do you think is the answer? So basically 30 weeks gestation, which is very, very important in this case. No fetal movement for the past 6 hours. The physician did non-stress test. The results are inconclusive. What do you do next? Of course, the first thing to do whenever the patient has absence of fetal movement, especially for around 6 hours, is non-stress test. Exactly, biophysical profile is the answer. We do a non-stress test. If the results are inconclusive or absent or negative, basically, we do the biophysical profile. Biophysical profile actually includes the non-stress test as one of the steps that you're going to do. So the non-stress test is basically looking for the patient's the fetal heart rate and monitoring its activity, basically as mild and as superficial as you can, because it's very quick, it's very fast and quick this way. And if the results are inconclusive, like in this case, we do the biophysical profile. I think I've had some notes here around the non-stress test, the fetal movement. Yeah, so basically it says that the fetal movement should be felt at least 10 times every 2 hours. Okay, given the 30-week of gestation age. The absence of this fetal movement is of course alarming. The first and easiest test to perform is the non-stress test. If the results were positive, which means that the fetal heart rate was detected, then simply assure the patient, because maybe the fetus is not moving very much, or maybe sleeping, or whatever, or the patient herself did not feel the fetus movement. This is very quick and very fast to do. If the non-stress tests were inconclusive or negative, i.e. you did not see the fetal heart rate, do the biophysical profile. Let's go, but I'm seeing some cases. Thank you. Okay. So basically, the biophysical profile is one of 4 aspects. You're going to do the non-stress test, and you're going to check the fetal tone, the fetal movement, and the fetal breathing. All of these 4, once checked thoroughly, they will tell you an exact, basically, hemodynamic and vital status of the fetal themselves, and you're going to assure the patient, or maybe take them to the OR. So if a female does not feel the fetus movement, you have to do the non-stress test. If the non-stress test was inconclusive or negative, we're going to go to the biophysical profile. Depending on the biophysical profile's results, we're going to move forward from there. I've already uploaded a video about the biophysical profile and how to interpret the results, but I'm not going to go through it here because it's going to be a long video then. You can just watch it after the stream. Okay, any questions? All right. So our second case, a physician is discussing starting haloperidol for a patient with schizophrenia. The patient read online about the many movement-related side effects of this medication. Assuming the patient takes the medication as prescribed, which of the following is the first movement-related side effect we expect to see? So basically, a physician is prescribing haloperidol, and the patient knows that there are some movement-related side effects. Which of the following side effects is the first that you'll see in this patient? Do we see tremors first, tardive dyskinesia, dystonia, or Parkinsonism? Okay, I'll give you a second. All right. So basically, the side effects of all antipsychotic medications are one of two groups, exactly. Are one of two groups. The first group is movement-related side effects, and the second group is body-related side effects, which would include hyperprolactinemia and basically weight gain and stuff like that, and sexual dysfunction and some other things. The first group that we're interested with in this case, which is the movement-related side effect, and the first that we'll see is dystonia, and the last one that we'll see is tardive dyskinesia. Of course, all of these side effects will present differently with different patients. The presentation themselves is different, but the timing is always the same, which means that every patient will have dystonia first before developing tremors, before developing Parkinsonism, and before developing tardive dyskinesia. This is the order that they go through. So dystonia is basically not stretching, but contraction of any muscle in the body. So it's basically unsustained of that contraction. So basically, the hand is contracted and it will stay contracted like that. Or maybe their eyelids is contracted shut and they will stay shut. Or maybe their mouth. Sometimes the muscles of mastication, whatever, any muscle at all. It can affect any muscle at all, but normally it doesn't affect big muscles like the spine or like the diaphragm or like the thighs. It just affects the small muscles and will continue to contract. That's dystonia. Parkinsonism is, of course, Parkinsonism with its many features. Tremors is, well, tremors, you're going to see tremors. And tardive dyskinesia is a repetitive contraction and then release of any muscle. And mainly the lips. So you'll see the patient's lips moving and smacking up and down. It's actually called lip smacking. Tardive dyskinesia is sometimes called lip smacking. Okay? So I think that's all the cases that I wanted to cover. Today's just a short video. Unless you guys have any topics that you want me to cover right now, I'm more than happy to. And next time I'll prepare more cases, I guess. So, do you have any topics in mind? Okay. All right. So I'll end it here. I'll see you guys next time.